and a lot of academic feast along with the competition. We have 5 teams with us. I'm going to introduce my umpire, Dr. Mohita. She'll just join in a little while later. She's in the other session. Of course, Mohita is the one who conceptualized it. And the way we go unique with our programs, we wanted this a little different. We have Dr. Diol with us. She is from Calcutta. And the coordinator, Dr. Sudipta, is with us. Hi. Sudipta is the HOD, Rabindranath Tagore International Institute. She's in the Department of Ophthalmology, heading it, Calcutta, and did her fellowship from Australia. And she's one of the very active members of WAS and also heading the state. Dr. Diol, she is also, I want her to introduce herself. Dr. Diol, go ahead.
Good afternoon, everyone. I am actually Dr. Doyle. Every time I'm introduced as Dr. Diol, people wonder how I'm a Diol without the bronze. So I am Dr. Doyle Biswas from Calcutta, and my moderator, co-moderator is Dr. Aarti Nangya. She is the unit head of Fortis, Vasant Kunj, and Fortis Escorts Hospital, Delhi. But most importantly, she is the state head of Women in Ophthalmology Society in Haryana, and she's also the executive member and Women Outreach Program, Women in Ophthalmology Worldwide. So once again, welcome, and I would just like to add something to what Dr. Aarti said. How is WAS OPL different? It is different because you have beauty and brains. In all other OPLs, you have one or the other. So, welcome once again.
Great.
Dr. Aarti.
Yeah. So, we're going to introduce our judges. To begin with, I think women first. Dr. Vandana Prasad, Dr. Cyrus Mehta, Dr. Tejas Shah, Dr. Vanita Ramani, and Dr. Purvi. So, let's go introduce one by one, all of them. And, of course, there's no bidding because, women are always fair. Fair for the complexion, fair for the ways we are. We are not the ones who are going to, go behind the table and bribe. So it's going to be a very fair way to go ahead. Dr. Chitra is not with us. Dr. Chandrima Paul, I don't see her here as well. So now then we have left with Dr. Tejas.
Dr. Tejas is the founder and director of Ahmedabad Eye Laser Hospital Private Limited. He is also the chairman of the scientific committee of the Gujarat Ophthalmological Society, and he is the founder and contriver of surgical skills transfer course since 2015, and we expect some very fair marking from him. As she said, it's all about being fair, whether you put it as fair or fair, whatever.
So am I supposed to?
Are fair, right.
Dr. Cyrus Mehta, are we done with Dr. Tejas? Yeah? I think to introduce him, I think his physique should speak more than his persona. He's really worked very hard, and if I'm supposed to really talk about that, I think he kind of gave in about a year or more to become fit. That's it? Oh, wow. It works so well. So he's, of course, MCH, FARS, CRS, editorial board, Eurotime, editor, IIRSI, fitness enthusiast. I think I really like this professional bit about him. Cyclist, motorcycle race. What does it mean? Motorcycle race, PN. Of the likes. Oh, he's a musician and also Rotarian. He's Chief International Eye Care Mumbai, of course. Purvi?
Next, we have Dr. Purvi. She is the professor and head of glaucoma clinic. She has won various prestigious leadership positions and committees, but the one that really stands out and which attracts me the most is outstanding work as a woman in 2015, and she's role model of the year 2016. Of all the things, I think that is what
for it, yeah.
WAS judge is all about.
Excellent. I think Dr. Purvi, you add always a feather in our cap, yeah? We have Dr. Vanitha Ramani. She is also very promising, very charming, very pleasant person, very capable. She is in Indore and she is the department head of a multi-speciality corporate hospital in Bhopal. She has a huge experience of 28 years, done huge number of surgeries, recipient award, whole lot of them. I'm going to cut short on that. And let's bang on start with our teams. Can I have the captains here for choosing who's going to go the first? So let me call upon the teams. I think we have very interesting names for them. We wanted to be different, so we are different names. We didn't want to copy paste the way the OPL is done, you know, typically the same names they've chosen. So here we are with the teams. We have the daredevils of South. We have the femme fatales of North. Let's make some noise. The queen bees of Center. The oomph princess of East. The ebony ethereals of West.
For the names, you know.
Absolutely. And I think we should acknowledge the fact that all the names actually celebrate femininity. So big round of applause for that.
So I'm going to introduce the captains. The rest of the work each team captain is going to do on their own. Daredevils of South. I see them really with horns. Going to really work on that. She's Shilpa Kotkari. She's such an amazing person and also very capable. So I'm going to have your intro done by you yourself. Let's have our first intro video, Sudipta. Let's have that. So the second team with us is Femme Fatals of North, Dr. Nilima Malhotra. Bees of Center, Meeta Doshi. The Oomph Princess of East, Dr. Sudipta Ghosh. The Ebony Ethereals of West. Very well the name selected by the captain herself, Dr. Suvira Jain. Let's have the intro of the video of the whole session begin with. Selection, Joel. We'll just go ahead with the selection. We'll have our intro and then yours. Like that.
Hit hard, call stand up. Hands
Yay.
high, hard to handle. Don't care, my halo dips. My right to this is worth the risk. Front pass, perfect champion. One chance to make it happen. Don't care, my halo dips. My right to this is worth the risk. Work, work, hala, hala. We work, work, da 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 da. Work, work, hala, hala. We work, work. It's a new day. More you wish you could join. It's a short day. Taking over the world. It's a girl
I think we need
So I hope that set the tone of the OPL for the rest of the event. And with that,
We have our judge with us, another one, Dr. Chitra Ramamurthy. Should we have you on the panel? We should have another chair. No, no, no. No, we want you to be with the other judges. Sudipta, we need a chair. Hmm? Yeah. अच्छा दो chairs लगा फिर. Let's have. Can we have two chairs on the dais? Two more chairs. Dr. Mohita Umpire is here. She's boss. She's wow. She's just about everything about wow as well, as in the true sense. She's the one who's conceptualized the whole session, and we should have you as a judge also. And she's going to be really, going to balance the fair and the unfair ways. So we should have you on the panel. Is here? Okay. Chalo, theek hai. Dr. Chitra? Just to read a little bit about your intro. You're the medical director, and of the Eye Foundation, a chain of 14 eye hospitals, wow, in South India. She's chairperson, who doesn't know that, and Academic Research Committee, AIOS 2020 to 2000 to 2023. Wow. Management Committee member of TNOA, highly proficient cataract, refractive, and glaucoma expert, a pioneer in refractive surgery, lot of surgeries in her kitty, and she's the also very active member. She's the one who's holding a high flag of ARC. We welcome you, ma'am.
Can we start
So
now?
let's have the selection criteria.
Uh, the selection criteria is quite simple. You have the best scientific video, the best orator, we have the best team theme, the best video or PPT quality, and we have the best take-home message. So on these, the teams will be judged. And I think since we all have flights to catch today, we should start immediately with the very first team. Dr. Aarti, the first team is? The
First team
Daredevils of the South.
is going to be selected on my hand. So I'm going to call upon the captains. It has to be a fair way to pick up the finger. Oh, okay. Let me just read. Okay. Yeah. Let me go one by one. Yeah. Remember, team one, Shilpa, is going to lead the show. This is team five. All right, so this is yours. Team two and team three. One, two, three, fourth here. Okay, fourth. Right. So, just to remind you, femme fatales. Wow, what a name. What else? So they have to be very exciting, very gratifying.
So we are starting,
They
I
have
think.
to speak their names of the teams. So we want women, fierce, and competing with each other. Let's have the first team.
The Daredevils of the South.
Timer, please. Timer, wait. Just hold on. Timer. 15 minutes. That's all.
Presenting the Diva Devils of the South, our captain Dr. Shilpa Kodkine from Belgaum.
That was an obvious challenge to all the other teams. Now, can we have the presentations?
This is a case where zeptocapsulectomy is being done. The pupil is about 6 millimeter dilated. The suction cup is positioned on the anterior capsular surface. And suction is applied as you can see the air bubbles coming into the cup. Once they stop, suction is achieved and zepto energy is applied to perform the capsulorhexis and suction is released. I find that the iris is adhered to the suction cup and nitinol ring. I tried to move the ring a little to try and release the adhered iris, but it is stuck to the ring. So I decided to use a spatula and release the adhered iris at both the places. It is difficult to disengage the iris at both these places, as you can see. And see what happens now. And when the probe is out, lo and behold, I have an iridodialysis. I use iris hooks to keep the iris away from the phaco probe, and this also prevents the dialysis from increasing.
have Dr. Soumya Ganesh from Coorg.
A very good afternoon to everybody. So I'm sharing with you a video on mature cataract with a myopic plaque. So I have kind of increased the time duration, rather the speed, so that we don't run out of time. So like you can see, this is a mature cataract, hypermature if you can say, and it's a myopic eye. The first message is that in mature cataracts, it's very important to be careful and not hurry anything. And like we all can agree, one of the most important steps is to get a good rhexis. It's very important to grasp and re-grasp as many times as needed to make sure we get a good central rhexis. And like you can see now, with multiple grasping, we've actually been able to finish this rhexis carefully. Once a rhexis is done, most mature cataracts are quite easy to handle, unless they're grade 4, in which adjust the power accordingly. Now we've managed to remove the cataract, the nucleus, and now we're coming to cortical aspiration, which usually is not as threatening to us than the rest of the steps may be. Now while doing aspiration, if you can notice, there's a grayish hue right in the center. Now this is a plaque on the posterior capsule. So our options to handle this plaque would be either to leave it as it is and then maybe do a YAG later, or we have an option of doing a posterior rhexis, or we could try and remove the plaque. So right now we've been able to manage most of the cortical aspiration. Most of the cortex is gone, and now it's becoming more obvious. You can see the plaque right in the center. It's not really easy, it's not coming off easily, so now we kind of need to think about what needs to be done next. So the AC is filled with visco. The plaque must be refocused, and you need to have a good focus on what you're trying to do. And here trying to lift the plaque with a spatula slowly. Fortunately, it's not complicated and it's coming off easily. One also has an option of using visco dissection technique to try and lift the plaque with visco, or direct the irrigation towards the base of the plaque so that you can come out easily. And now you can see there's a small ring left, but I'm not going to bother about it because it's not in the central axis, and it's best not to complicate things more than it needs to be. Sometimes it's just blah, which means better left alone. So the periphery can be left alone as it is. Following this, very uncomplicated IOL implantation, and this winds up the surgery. Thank you.
Excuse me.
Now we have Dr. Dipti Joshi from Hubli.
Hello everyone. In this video, we present 3 cases of strabismus following scleral buckle. Following a retinal scleral buckle, strabismus is very common. Why does this happen? The first, it's because of the reaction to surgical trauma. Second, explant disturbing the functional direction of the muscle. Third, direct trauma to the muscle. Or fourth, an infected explant causing dissolution of the muscle. In this video, we present 3 such cases and their appropriate management. The first case is of a young male who presented to us with diplopia following a scleral buckle surgery. He had a 20 prism diopter exotropia, and we managed it conservatively using prism glasses. Voila, the diplopia disappeared and a happy patient. The second case is of a young male again who presented to us with strabismus post-scleral buckle with 25 prism diopter of exotropia. We did try a prism glasses, but there was no relieving of diplopia, hence we planned for a surgery. Easy peasy lemon squeezy. No, lemon squeezy can be messy too. Once inside, we had extensive fibrosis which made isolation of the muscle very difficult. We released all the adhesions, dissected the muscle carefully, cauterized the bleeders, and then performed a perfect resection. To prevent extensive fibrosis and to cover the bare sclera, we used amniotic membrane. This is day 1 post-op and this is 2-week post-op. So when life gives you lemon, make lemonade. Third case is of a 35-year-old male who presented to us with the strabismus after his infected buccal was removed. He had 45 prism diopter hypertropia. He wanted his cosmetic disfigurement to be dissolved. We planned an inferior rectus resection and superior rectus recession. But what is this? Once inside, we noticed there were no muscles at all. They were totally dissolved with the infection of the implant. We were in a maze. What do we do now? We changed our plan. We isolated the inferior oblique muscle and placed it at the site of inferior rectus to aid the downward movement of the eye. Use of mitomycin pledgens was done to prevent the fibrosis again. And this is the post-operative outcome as compared to his pre-op with a small residual deviation. The maze is solved. So my friends, the take-home message is, in such cases, try non-surgical means like prisms. Use appropriate antifibrotic measures when required. Modified strabismus surgeries like adjustable and hangbags are necessary. And finally, be flexible to change plan. Thank you.
Now we have Dr. Asmita Patne from Gadinglas.
देवी और सज्जनों, यहाँ पर अनेक राज्यों से पधारे आप सबका स्वागत करता हूँ.
A warm welcome by one and only Amitabh Bachchan. Is he? No. He is Mr. Sashikant Pedwell.
अक्सर जो दिखता है वो होता नहीं और जो होता है वो दिखता नहीं. इसलिए सोच समझ कर हर चीज को जांच कर निर्णय लेना चाहिए. Don't be too quick to judge.
Our first case referred to me for TPK, almost limbus to limbus corneal infiltrate. Within 5 minutes, the infiltrate was gone. It was a dense plaque which is characteristic of fungal keratitis. The second case referred to me as worsening superficial corneal infiltrates. He came with the BCL on. I removed the BCL and they were all gone. Basically, there were deposits under the BCL and few sticking onto the epithelium. History of sugarcane injury 2 months back. It looked like a lamellar flap, but what are they? The deposits, the foreign body and infiltrate? As the edema wasn't settling, I wanted to open the flap, wash it and take out the suspicious thing. Patient denied history of any eye surgery. So as I opened up the flap and tried to trace the foreign body, it was very difficult. I was struggling to get in there to get hold of it just when the patient suddenly looked down. And there is a circumferential extension of the wound. Did I worsen it? No. Does it look like a LASIK flap? Have you undergone any eye surgery before?
No.
Did you undergo any laser procedure?
Yes.
Finally, I got what I wanted. Patient had undergone LASIK At the age of 17, 15 years back, a farmer because he wanted to join the army. The epithelium was growing over the stroma and under the flap. I tried all the means to get rid of it and then left tomycin C to take care of it.
जो दिखता है हमको लगता है
Time up, time
मेरे
up.
हिसाब
We're
को
going to
लगता
stop
है
there.
नहीं है लेकिन
Time up.
जो दिखता है वो नहीं होता और जो नहीं दिखता वो होता है
Wow.
We are the
Remember?
divas, but we are devilish too.
Excellent. Theme of the team. One of the criterias. Excellent videos. So do we
Dr. Aarti.
challenge? Yeah.
You think that's excellent? Let's go to the other teams.
Yeah.
Let's ask the captain of the East. Oomph personified herself. Do you really think the Daredevils were daring
Oh,
enough?
they
or do
dared
you
her.
think they were just covering it
They
all up with a lot
dared.
of music?
You bet they dared. They dared you guys, yeah. So I guess anybody to answer that? Let's have the other team
A
coming
simple white cataract. You thinking of the plaque? You're going to eat it up? Huh? You use the spatula to move it? What if it pops out? You're going to pop yourself. Your eyes are going to pop out once the vitreous pops. Pop, 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 pop,
in.
pop.
Challenge. Answer. Where are we? North? No, no.
That happens only when you're not diva enough. When you're diva enough, you can handle anything.
You are demons with the horns there.
Divine devils, that's a new word that's been coined. We could add it to the Oxford Dictionary. Divine devils. Okay. Next team, please.
Excellent. Excellent. You guys did. Excellent.
my heart and home to die I don't need another guy to fight my battles to overshadow me don't you know I'm dangerous fire burning in my blood I got this handle I don't need to rescue you you can call me a princess you know cause you like to keep me helpless beside but I ain't wrong I'ma show you
Wow, they're going to be not one, not two, not three, now four. Four queen bees.
And that was some catwalk if I ever saw one.
Right. So after that catwalk, what do the queen bees remind you of? Honey, obviously. So honey is very sweet. The bee which gives it to you is then again the queen, but she carries a sting. And so we deal with it. And so we deal with the sting today, which is carried by one of the most common medications which we use, the steroids. The steroids in corneal ulcer. We had this case of a 65-year-old male coming with history of redness of the eye associated with watering and foreign body sensation. There was no other significant clinical history, no history of trauma, no other diabetes or hypertension. And he took over-the-counter medications for the redness of his right eye, and he felt good with that. And then, after a few days, the symptoms worsened. When he came to us, his vision was finger counting close to face, mild lid edema, congestion, and a central corneal ulcer of 5 to 6 millimeters in size, with pigmentation and thinning, and a hypopyon of 2 millimeters high. The scraping was done, which showed filaments, and we started him on antifungal medications, oral ketoconazole, natamycin eye drops, voriconazole eye drops, and intralesional amphotericin B 5 micrograms. The patient improved symptomatically, the hypopyon was reduced, and the infiltration also came down. So we know that the ulcer is associated with inflammation. We always feel that jahan inflammation hai, wahan steroids hai. But then, does it always work? The mainstay of treatment in an ulcer is the topical microbial agent, whereas the use of adjunctive topical corticosteroids remains a matter of debate. How does the steroid work? It usually inhibits the neutrophil chemotaxis and reduces the collagenase and cytokine burden, which leads to the ulceration and then the scarring. The benefits, if used in time, it can reduce the severity of neovascularization and subsequent scarring. But then there are agents in which it is not very helpful also. The risk, again, as we all know, and which we saw in this case of use of over-the-counter medications, the immune response is suppressed and inflammation can lead to prolonged organism replication, corneal melting, delayed epithelium healing, and neutrophil inhibition. So when to use? Only with the antibiotics and once the infection is controlled or eliminated, and along with the antiviral cover in case you are suspecting a viral etiology. When not to use? Never empirically, never over the counter, in fungal cases, in HSV where the epithelium or the stroma is involved. And this is the steroids for corneal ulcer trial, and they concluded that it can be used in certain cases, but then again you have always to be very careful and beware of the sting of steroids. We now have Dr. Shweta Walia, Professor, MGM Medical College, Indore, and one of the pillars in our society.
So our theme is sting of steroid. So I am presenting a case of recalcitrant scleritis. So 45-year-old female presented with complaints of ocular pain and redness and swelling. There were no systemic illness. It was simple case of right eye scleritis. I thought it was an easy cakewalk. And depending upon that, I started loteprednol, but the patient had no response and we switched to prednisolone eye drops. But there was no response, and we've noticed that there were sentinel vessels, episcleral vessels that were prominent, so we investigated the patient, did thyroid function test, did MRI, and added systemic prednisolone. Patient presented 7 days later with an increase in intraocular pressure due to steroids, and we added AGMs. But 6 days later, what happened? The patient had diminution of vision. And when we saw the fundus, there was CSCR, and when we did OCT, it was clearly CSR. So it was clearly a case of steroid response. And we were in a dilemma what to do now. So we took a rheumatologist opinion, and he advised ANA, and steroids were withdrawn, immunosuppressives were added both topically and systemically, but to our dismay, the patient could not tolerate the tacrolimus that we had given. He had an allergy to it, and we were like, what to do? Badi mushkil. So we had to withdraw the tacrolimus, added cyclosporin, and 2 months later, the CSCR resolved, the pressure came down with systemic methotrexate, folic acid, and topical cyclosporins and nepafenic. So the role of immunosuppressives is great in the cases of steroid responders. What was appearing like a cakewalk turned into so much of thinking and doing so much. However, 3 months later, the eye was quiet, pressure control, systemic methotrexate was stopped, and she is in consultation with rheumatologists. Take-home message is that scleritis and episcleritis can be the presenting symptoms of connective tissue disorders, and rheumatologist opinion should always be taken. Thank you.
Good afternoon, beautiful ladies and gentlemen. I'm Shruti Maru from Indore. I'll be presenting a case on faking IOL, and I have no financial interest to disclose. Thank you, Voss, for this wonderful opportunity. So, after careful selection and planning, I thought it's okay, let's do ICL for this lady. She was having a spherical of -7, -2. Everything was done perfectly. Her pre-op assessment was absolutely fine, no abnormality. Online calculator, perfect IOL sizing, everything was fine. The surgery was uneventful. Very happy. Post-operatively started on steroids and antibiotic drops, but she did not come for first day follow-up. COVID, whatever reasons. She came on day 4 and terribly unhappy. She ate my brain. She was very, very unhappy. She complained of headaches and made my life difficult. So on evaluation, the pressure was really high, 35 millimeter of mercury. She had corneal edema. So why is the pressure high? Is it just the retained viscoelastic, high vaulting, or is it steroid responsiveness? My brain started to think, overthink. Should I go ahead and do AC wash or explant the IOL or taper the steroid? What should I do? What am I dealing with? Is it overvaulting? Yes, I did ASOCT. It was definitely high. It was 1300 micron. Vault was definitely high, but the angles were open. Wait. Let's not jump into ICL explantation. I thought, let's taper the steroids first and try. So what I did was I changed the Predfor to FML because it was just 1 week post-op, and added an anti-glaucoma, and oh yes, it was again 6/6 after a week's time. So a step ladder approach is really very important. Let's not just vault, let's explant. No, it's not the solution. It can be open or closed angle. And let's think of steroid responsiveness as the only thing and not jump into any conclusion of explanting the lens. So depending on the time of presentation, anterior angle, anterior chamber angle and ICL vaulting and other features of glaucoma, understand the possibility of steroid responsiveness first and then take any measures ahead. And this prevented a drastic step like ICL explantation in this case. Thank you so much.
Good afternoon, everyone. I am Dr. Neetu Kori from Indore.
Good afternoon, everyone. It is rightly said, when the going gets tough, the tough gets going. So I am presenting 55-year-old female. She is non-case of primary open angle glaucoma since 2 years, presented with chief complaints of headache and ocular pain since 22. Patient was putting combinant eye drop. Best corrected visual acuity of right eye was 636 and left eye 66. GAT with combinant eye drop right eye 32 and left eye 24 millimeter of mercury. Pachymetry with normal limit angles were open. Patient gave history of hospitalization of 13 days due to COVID-19 infection 4 months back. it or reported that steroid-induced effect is greater in glaucomatous eyes compared to non-glaucomatous eyes. Proper counseling of the prognosis of glaucoma is very important. Thank you.
Of
Yeah,
course
sure.
we are.
So, I mean, really, when you put in ICLs, it's only an excuse when you say patient didn't show up next day. You definitely want to see them, no, the next day. कोविड हो तो फिर ICL मत करो अगर देख नहीं पाओ अगले दिन तो and and secondly वीडियो कॉल पे IOP हराइज समझ में आता है अच्छा all right learning for us also I mean would you really call it steroid responsiveness that's my question to the glaucoma guys here steroid responsiveness takes a little time not overnight yaar most likely I would have thought this would have been fourth day but she turned up on the fourth day then she should at least come on the second don't you think oh then she realized all right okay
Queen Bees, most of your cases had to do with rise of pressure and glaucoma. Did you look at the panel of judges before deciding what you would want to do? So many glaucoma specialists here. Next team. Big round of applause for them.
Please welcome the
Femme fatals. My God, there's a lot of oomph in them, yeah. So each one of them is going to challenge the other teams.
Good afternoon, all boss and all bosses here. So we are from the north and we are always there for each other. So after having such a big dose of things not going well, let's have things going well for a change from north. So don't go to the center, don't stray too much away from north, and here's what we bring you. So our first presentation is from Bareilly, and history has it that when people from Bareilly come to Mumbai, Miss World happens. All right, so we have physicians, can they ever scare surgeons? We had a patient, 16-year-old, with bilateral white total cataracts for the last over 1 month. But no, that wasn't it. She had diabetes, tuberculosis, and she was bilaterally blind, and she had UTI, all conditions which would worsen the eyesight. And this patient, when she was bilaterally blind, she was really unhappy, as you can see here. So the challenges for us was her diabetes, her juvenile type 1 diabetes. She also had secondary amenorrhea, probably because of stress. So her poor vision, her blindness caused a lot of stress to her. UTI is one condition which really scares anybody for infection inside. So these were the two major problems in this patient. She was on ATT as well. And physician clearance, that is very difficult to get. 16-year-old, would she be cooperative for surgery? What sort of surgery should we take her in for? And what about the status of the retina? All right. But if your physician doesn't give you clearance very easily, they give you verbal and not written clearance, don't be put off. Because take your precautions and go ahead. Be brave, not foolhardy. So her type 1 diabetes was uncontrolled, even on insulin, but we put her on 12 units of regular insulin and human insulin Lantus HS. You can see her sugar would go up to 296 and down to 83. We had an endocrinologist taking care of the blood sugar levels. Retinopathy, all of us know that retinopathy generally doesn't happen in type 1 diabetics within 5 years of their presentation. However, up to 30% of patients can still have it. Pulmonary tuberculosis, she was started on HRZD regime, and ethambutol, you know, causes toxicity itself. Secondary amenorrhea in a 16-year-old unmarried girl, stress is probably the likely factor. UTI, the blood culture was normal. However, her urine sugar was high, and urine also showed candida on fungal culture and QOH. Cost of treatment is sometimes what we don't think. You saw the previous presentations, the duration of treatment, all that adds up to the cost. And so many of our patients are very, very low society, and cost is, of course, always hurting. And this is a patient who's a juvenile diabetic, likely to have treatment for the rest of her life. So pre-op workup was done. The most factor which was disturbing was the UTI. The surgery was done after hospitalizing her and controlling her sugar, starting her on anti-UTI, on antibiotics for UTI, antifungals as well. First post-op day, she was good. Vision was 6/6. MICS was done under topical anesthesia. Patient was cooperative, and patient wanted the other surgery. However, we delayed the other surgery by a week so that her sugar could be managed, and also no signs of endogenous endophthalmitis in the operated eye. These are her fundus appearances. OCT macula post-op, she was doing well after both eyes. So can surgeons ever scare their physicians ever scare surgeons? So it is never. You can see this is a video before her right eye was operated. The left is already operated. So a happy patient in this case. The take-home message being, don't let small little things scare you. Now we have Dr. Iram, who's leading from Muradabad, a very, very active WAS member, and she's going to show you a presentation as well.
Good afternoon, everyone, and thank you, WAS, for giving me this opportunity. It's taking time. So the topic today is intraoperative complications. You have the solution, don't panic. So what it is all about, in this I'm not going to tell you how to manage a case, but we all have seen cases which are moving, which are roaming around in the city from one surgeon to another, with subluxated PCIOLs, subluxated lenses, sometimes PCIOLs implanted in the anterior chamber with no PI, and obviously PCIOLs in the AC, and with aphakia, with vitreous in pupillary area, with vitreous in ACs. So all those complicated cases we all have seen. So few days back, I saw this patient. Although this photograph is not clear, but this is, here you can see the haptic of an IOL. This haptic is not subconjunctival. It is actually outside the, it is actually exteriorized, and the conjunctiva has ensheathed it. So when I saw this case, I thought that I will be speaking on this topic. So I decided, I thought, why would a surgeon will leave such case, would do a case like this and leave it as it is. So I thought, I think we need to condition ourselves, to overcome the stress we feel at the time the complication happens. We manage peri-op complications and intra-op complications, but during the surgery, when the complications happen, we tend to succumb in that short period of time when we have to decide, we have to manage the case. So I think we should condition ourselves that we should not think about the implications it will have. We should not think about what will we explain to the patient, what will we tell the attendants, what will be, whether the patient is VIP, whether the patient is Amitabh Bachchan or a villager. I think we need to condition ourselves so that we all have the solutions. We know the management, how to manage a case, but we succumb to the fear at that particular of time. So I think we should condition ourselves to overcome that fear. And it is for all the surgeons, all the surgeons are good, and we keep on improvising ourselves with every surgery we do. But I think we need to be mentally strong to take the right decision at the right time. And a very good alternative to people with aphakia, with subluxated lenses, with such syndromes, now we have a very good option of posterior iris claw lenses. We can implant it primarily or secondarily. These do not need a longer curve, learning curve. You can ask your fellow colleagues or friends, or you can attend SSTCs and you can implant it and can give very good results. So you should not panic. Whether it can be any complication, you can manage it. If it is a intumescent cataract, you can do the rexes. If there is iris prolapse, you can manage it, but you need to have a calm mind. You need to have a calm mind to focus and do what is really needed. So this is, I dedicate to all the surgeons here.
And now next we have Dr. Vidhi Singh, Vibha from Noida, from the center of the country, but still in the north. So we have Vibha taking over from NCR.
Very good afternoon, everyone, and thanks to WAS giving me this opportunity to present my case. In a few seconds, just I start. I just present isolated eyelash in anterior chamber. It is an unusual intraocular foreign body following an indolent self-sealing corneal rupture with a reversible lenticular opacity during the COVID-19 era. There is no financial interest and there is no conflict of interest to declare. In a regular OPD, 14-year-old male boy present with the trauma to broomstick were present with the foreign body sensation, redness, pain and blurring of vision. On examination, the vision in right eye was 618 and left eye was 66. On examination, we can see there is a curled in eyelash with a bulbous end at 11 o'clock and localized lenticular opacity was present inferior to the adherent eyelash. Rest examination was within normal limit. To manage the case, we started a systemic steroid and topical antibiotic. Patient was posted for the foreign body removal under general anesthesia, and during a management period, localized lenticular opacities increased. To manage the case, surgery, we made a side port with the MVR blade at 2 o'clock. Adhesion between the eyelash and anterior lens capsule was released. Foreign body was removed with the McPherson forceps, and on histopathological examination is confirmed to be a eyelash. On post-operative day 1, best corrected visual acuity was 6.9 and systemic corticosteroid were continued. Topical antibiotic steroid eye drop was given. In the discussion, we can see there is always a good prognosis with the early intervention, which is very crucial decision, but always with a rewarding result. To conclude my case, intraocular cerium has a variable presentation and always need a individual management. In my knowledge, it is a first reported case with the eyelash in anterior capsule associated with anterior chamber with associated reversible anterior lenticular opacity. My take-home message is, do not panic. In any case of trauma, surgery may cause reversal of anterior capsular cataract. And early intervention should always be advocated in such cases. This presentation emphasizes that early intervention is very crucial and may reverse the lenticular changes. If we delay intervention, is required additional cataract surgery. Thank you so much.
Next we have from Bareilly, SRMS, our senior resident, Dr. Elia Yamin, who's soon going to be a assistant professor. She'll be presenting a very interesting case on a very unusual diagnosis of a common condition. So since time is a little short, please pay attention to this very interesting presentation.
A very good afternoon to everybody. I'll be presenting a very interesting case of unilateral proptosis and show to you all how rare can be the new common. So on a very busy wintry December morning in our OPD at SRMS IMS Bareilly, when the cataract was at its peak season, there walked in a young male 29-year-old with unilateral proptosis. And as we would go about thinking about it, the first diagnosis would pop in, he definitely has thyroid eye disease or orbital cellulitis. We won't even give consideration to all of these differential diagnoses. But let's see what happened. So patient had protrusion of left eyeball with diminution of vision and also had left nasal obstruction along with discharge. There was no history of the other like pain, redness, diplopia, no neurological signs, no history of fever, weight loss, trauma. And on examination, the vision, the left eye was 260. There was a reduced color vision. There was on exophthalmometry, the proptosis was 28 mm, and the movements were also restricted medially. The proptosis was non-reducible, non-pulsatile, there was no variation with posture and no lymphadenopathy was there. And very interestingly, this patient also had a full thickness inferior iris coloboma along with type 3 choroidal coloboma. There was also hyperemic disc along with tortuous vessels. On ENT examination, there was a pink lobulated rubbery non-febrile mass that was present in the superior and inferior turbinate extending into the nasopharynx. So the moment of truth after our investigations on NCCT head and orbit, we found out there was thickening in the nasal cavity and involving the maxillary, ethmoidal and frontal sinuses. On the MRI also, we found out there was involvement of the frontal sinuses and the maxillary sinuses extending into the left orbit through the lamina praepatia. Then
Time up. I'm so sorry, that was an interesting case, but you knew your timing. Anyone from the Daredevils here? So, can we have a comment? Oh my God. You are too young, you're still a daredevil, you're a devil, it doesn't matter. And please, you make me feel old when you say you're too young.
Any other comments allowed? I mean, really, in this last case, honey, I mean, would your second diagnosis actually be what it was? I mean, you suggested it could be an orbital cellulitis. It was a protruding eye for sure, scleral show, large eye. Orbital cellulitis? Really? But thoda sa redness, thoda sa pain, thoda sa fever. Oh, so he might have steroids and therefore you weren't sure. Oh, okay, that fits. Thank you.
नमस्कार बंधु ये रहा कलकत्ता की टीम from east the influences of east the Durgas Dr. Aditi Dr. Joyita Dr. Sangita and myself Dr. Shurita. So give a big round of applause for team east. First present is Dr. Aditi.
A very good afternoon to all. Namaskar from the east. So how many in the audience have seen oculosporidiosis? Anyone? Great. So was it bulbar or tarsus? So the thing is, oculosporidiosis itself is very rare. That too, bulbar is more rare, plus with a large staphyloma. So here's the case. So a little bit about it. What is it? It is a granulomatous infection of the mucous membrane caused by Rhinosporidium seaberi. It is mostly seen in nose and nasopharynx and followed by eye, where it is, as Sir said, tarsus, then bulbar, followed by lid. So here's the case. He was a 23-year-old male who presented to us with a mass in the eye. He said when he looked straight, no one could see the mass, but when he lifted the lid, the mass could be seen. So here's a look at the mass. And it has been increasing since last 1.5 years. There was no pain, there was no diminution of vision, there was no history of trauma, surgery, animal contact, or any systemic disease. There was a history of positive pond water bathing. There was no other similar masses in the body, and there was no history of ENT bleed. So here's the on examination. If you see, it's a large staphyloma. You can see the size. It was approximately 13 into 17 millimeter, and it was 3 millimeters superiotemporal to the limbus. So here's the classical features which helps us in the diagnosis of oculosporidiosis. This are polypoidal lesion with multiple yellow dots, subepithelial bodies, which are called as sporangia. The mass moves over the swelling. So other eye was not involved. The tarsus was not involved. You have to evert and check whether the common sites are involved or not. And the fundus was normal, and always send an ENT referral to rule out any systemic involvement. The other eye was normal. So we did an ultrasound biomicroscopy to plan the surgery. We had to see whether there was any scleral dehiscence or not. We could find a large anechoic mass with a scleral thinning. So a provisional diagnosis of oculosporidiosis with a large staphyloma was made. So the plan was surgical excision in toto of the mass, send for HP, cauterize the base, shrink the staphyloma, and post-op to give dapsone. Why? Because we don't want a recurrence of such cases. So here's a look at the video. So here you can see we performed it under general anesthesia. We have to remove the conjunctival lesion in toto. We don't want to leave out any sporangias. Why? Because they will cause recurrence. They will lead to further melt. It looks easy, but it is very difficult to take out the conjunctiva, remove it from the thin scleral bulging. We don't want the balloon to burst. We don't want to perforate the eye. So here's the mass. We send it for HP. Cauterize, but don't perforate. So the energy should be very minimal to just shrink the base and not injure the eye. Once you have shrunken, you can do an paracentesis to reduce the pressure, put a large scleral patch graft, oversize the graft, then followed by cover it up with a tenon pedicle and a conjunctival pedicle. If we had sufficient conjunctiva because of a good dissection, otherwise we would have used an amniotic membrane. I like to use sutures no matter whether I use fibrin glue or not, and cover it up with a BCL. So the HPE was confirmative of rhinosporidiosis. So the challenges, the size of the lesion, chances of perforation, difficulty in the suturing process because of the very thin sclera, and post-op, the chances of the conjunctiva to retract, the scleral graft to melt, and recurrence. So here are the results. We can see the graft is taking up. At 1 week, here's the 9-month. Post-op, we give steroids to the patient and an oral dapsone. This is the 3-month. We can see a large, beautiful scleral patch graft. And this is the patient at 2 years of post-op follow-up. This is one of the largest scleral patch graft used for a staphyloma and has been published in IGO this year, January. Once again, we can see very large staphyloma, and here how we covered it up. So this is what you should not miss out whenever you see a staphyloma. So all staphylomas, please look for these minor corpuscles. So to conclude, we should always have a good clinical diagnosis to identify such minor changes. ENT evaluation is a must. Treat the eye in toto. Think about the recurrence. Just surgical excision is not the aim. We have to think how we have to save the globe. Early diagnosis intervention is the key to avoid perforation. Thank you very much.
Yes. Coming up next is a case presentation. Our technical team is a bit slow, but we are faster. They are not coping. Oh, oh. Okay. So it's not this.
Just a second. Yeah, that's fine. It's okay. Right, so coming up is a case presentation from your East team captain. So what we can see is Tamisya Jyoti Mriga from darkness to light. So here I present a 65-year-old lady who was on dialysis thrice a week. She's hypertensive, diabetic, thyroid with uric acid. She suddenly complained of sudden loss of vision in the left eye. So we took her up for examination. The right eye showed 6 by 12. Left eye was counting finger 3 meters. She was a myope with bilateral cataracts and S2 posterior subcapsular cataract. On fundus examination, right eye was normal and left eye landed up with superior temporal branch retinal vein occlusion with macular edema. So what are we supposed to do next? So we went in for investigations. We conducted the OCT. The right eye was normal. Left eye showed us clearly a cystoid macular edema. So we decided to go in for an intravitreal injection of anti-VEGF. What happened next was the vision improved within a week to 6 by 18 N8 and the fundus picture cleared. Although the disc pallor had come in, the patient was happy. I was happy too. Now what happened next? To my horror, what I got the news was the patient went in for ventilation for 19 days. And the patient came out to be blind. She had no vision bilaterally once she was out of ventilation. She had hand movements both eyes. PL was positive, PR was inaccurate. A non-ambulatory patient and reported to me after 1 month. What I did was I sent her for a color Doppler imaging to find out the ocular perfusion pressure, and yes, the resistivity index was high. That means the perfusion pressure of the optic was gone down. We put her on dorzolamide, non-steroid anti-inflammatory, and tablet European 4. The decision was for cataract surgery was taken after proper cardiologist and nephrologist opinion, just in the hope if I can improve a bit of her vision. So what happened? Suddenly the patient after cataract said, "Ma, mujhe sab dikh raha hai, ma." I was ecstatic. I was jumping in joy. The right eye she improved to 6 by 36 vision, while the left eye was 6 by 60. कम से कम कोई तो मिल गया, कम से कम patient को आँख तो मिल गई. So what we need to do is, in cases of uncontrolled hypertension, strokes are very common. The management of this case was absolutely on compassionate ground. I was lucky enough to give her back a bit of a vision. We should all realize that patients who are on ventilation do have compromised ocular perfusion pressure, and patients of multiple comorbidities can have an effect on their optic nerve. Hence, when God gives light, it gives it all, but not all are lucky in life. Thank you so much. Next coming up is Dr. Sangeeta. She's going to present.
So I'll directly go to my video without spending much time. So it was a simple case of ERM surgery. I'll just directly go to the video. So
We probably eat more wrist treats than he has. Anyway. That explains the wooden personality.
So it was a very simple case of ERM, which is very commonly we do. As you can see, I'm so why is it not playing? Can the timer be paused, please?
Hang, हैंग हैंग हो गया माँ दुर्गा
Shudipta, no
Without the
extra
video
points
that-
for histrionics.
Without the video, it doesn't make any sense actually. So that was I just wanted to show there, the ILM forceps got stuck there. Yes. একটু forward করে थोड़ा forward करके चला So here it got stuck a little bit. Don't do anything else. Here it broke. Leave it. कुछ नहीं करना है आपको. अच्छा. टाइमर आप लोग वहाँ से कुछ नहीं कर सकते. So the island forces broke there, and after that, it's the same thing in slow motion. Ma'am, pause को ले. So I'm trying to align it longitudinally because it is a longer foreign body. It acts and it fell down. Okay, I'm stopping the video.
Okay, next coming up is Dr. Joyita. Time is running.
Good afternoon, everybody. Thank you all for the opportunity. Here I will unravel the ghost. Here is a case of 45 years old gentleman presented with a large nodular mass growing rapidly since last 3 months. There is no history of trauma, painless. It was a painless mass but blade on minor trauma. On examination, it was a pedunculated nodule of more 34 millimeter diameter. The color was dark red with some bluish tinge and chalky white spot. It was a firm mass which was the overlaying skin was adhered to the mass but not with the underlying structure. On imaging, you can see there is an oval shaped lesion which is iso-intense to the muscle on T1 but heterogeneously hyper-intense within T2. And the mass was abutting the orbital septum and extending to the frontal scalp. So the differential diagnosis came into our mind is it could be a dermoid or epidermoid cyst, it could be a vascular tumor, lipoma, epidermal inclusion cyst, foreign body granuloma. So the management plan is wide local excision with 4 millimeter margin under frozen section, and the defect is reconstructed by full thickness skin graft and forehead advancement flap. And the mass was sent for histopathology. And where is the ghost? On histopathology, we found that it is a well encapsulated mass lined by epidermis, which is formed by nest of basaloid and a ghost cell, that is a eosinophilic cell. And this confirms the diagnosis. It is a case of a pilomatrixoma. Ghost cell are the specialized cell which are actually the dead epithelial cell, looks like pale eosinophilic cytoplasm, but it is without a nucleus. And presence of ghost cell in histopathology is a characteristic of pilomatrixoma. This presence of ghost cell is rare in tumors. Other tumor which presents in ghost cell are usually some odontogenic tumor and craniopharyngioma of the pituitary gland. Pilomatrixoma is actually a benign growing tumor which originates from the hair follicular matrix cell. It is usually present within first 2 decades of life. The size is 0.5 to 2 centimeter. The one ghostly thing here is the diagnostic accuracy of clinical diagnosis is only 30%. Yes, I'm continuing. Rarely it recurs after excision except the subvariety of proliferative pilomatrixoma. Okay, fine. Our case was a proliferative one, and this is the post-op result after 1 month. It is healthy healing flap. And in pilomatrixoma, the points to remember are it's an uncommon tumor, and it is a mostly underdiagnosed tumor with a clinical diagnostic accuracy of only 30%. And ophthalmologists should suspect a pilomatrixoma as a DD of periocular nodule. Wide local excision biopsy from the mass with a proper lead reconstruction is the key, and very close follow-up, especially in case of proliferative pilomatrixoma after surgery, is advisable. Thank you.
Thank you. Thank you.
And Aarti, don't miss out on their attire. Apron with a crown. Embodiment of the modern woman. And I know from reliable sources, Shudipta was also carrying a kitchen knife which the airport authorities didn't allow her to bring. Next group. The young devil, do you have a question for the oomph? From the east?
I just have a comment that all of us have a feeling like we have got myasthenia gravis because in the beginning our eyelids are all wide open. At the end of the presentation, they're all drooping down.
We all know that black is beautiful. But how many of us really know that black can really deliver dazzling content? I present to you the ebony ethereals, the black beauties of the West. Sound, please. Just a second, pause. Lights off.
Here the intraoperative OCT was very useful to confirm the UBM findings. So we decided to do a periotomy first. The drainage of the cyst was done. It was a huge cyst involving about 10 to 12 millimeters in size horizontally and vertically, and about 8 millimeters horizontally. That's the intraoperative OCT giving us live feedback. This is the excess scleral rim which is being removed, because here I decided that let's not de-roof the cyst completely. Instead, just remove the rim, remove the excess keratinization that's occurred on the cornea and smoothen it with the help of IOCT. That was very easy, so that I could ascertain that I'm not shaving off too much corneal tissue. So the IOCT tells me how rough the edge is, the cornea surface is, and that helps me smoothen it. After polishing the cyst walls, I decided that why not glue the cyst walls together instead of excising or de-roofing and putting in a new scleral tissue. It is better we preserve the sclera of the patient itself. So glue was applied and the scleral lips are sealed together. The IOCT demonstrates the complete closure of the cyst. That's the amniotic membrane which is being applied over the cyst wall, which will cover the sclera as well as the cornea. And then the conjunctiva is closed with non-absorbable 10O sutures. And that's the end of this video. Thank you.
There are certain days when everything goes perfectly and certain days wherein you have to improvise. So this lady presented to us with a clinical and radiological diagnosis of a pleomorphic adenoma of the lacrimal gland. So instead of a classic Stallard right, I went ahead with the upper eyelid crease incision with gentle dissection till the superior orbital rim. So the surgery was done without any damage to the lateral canthus. I decided not to remove any bone unless it was really required. The rim was exposed, the subbrow fat. A gentle incision was taken so that the periosteum could be opened up. Extremely careful dissection of the periosteum was done so that it could be sutured again, following which the periorbita was excised. Very gently, I exposed the anterior pole of the lesion on cutting open the periorbita and found that the lesion was quite soft. So I decided to not go ahead with any bone trimming or lateral orbitotomy. We had the cryo ready at this point, but like certain days, everything doesn't go perfect and the cryo did not work. So I had to think of something else. So what I did is I passed a suture through a piece of gauze into the main stroma of the lesion after ensuring complete gentle dissection, and with very gentle traction we pulled out the tumor. After removal of the entire lesion, we ensured a complete hemostasis. We checked the cavity repeatedly for any leftover tumor residue. We washed it with saline and cleaned it thoroughly with gauze. So we could ensure this without any damage to the canthi, with zero damage to the bones around, to the levator or to the globe. So just the lesion was removed. Now in any orbital surgery, adequate hemostasis is most crucial. So after that, we ensured that the cut periosteal edges are opposed well with vicryl sutures. Throughout the surgery, we kept checking for the pupillary reaction. So we removed a tumor which was almost 2 centimeter in size through a very aesthetic upper eyelid crease incision, which healed very well and remained hidden. And the patient had been resolved of her proptosis and diplopia.
So here's a patient who was operated in a town, oh, about 7 hours drive away, comes to us a week later like this. And he came to us last week and he's 6'6".
Although these days we get away with anterior lamellar
Thank you. Any questions? We are happy to take any questions from anyone at any time.
Can we have the lights?
The videos were really very nice, very fabulous videos.
Very happy to see the creative part of the US. Excellent. Just need to fill up some more science. Thank you.
Very well organized and better than having to sit and see 30 cataract videos.
Beautiful, what a remark. I will create a plot for this.
It's actually infotainment kind of a session. Lots of information, knowledge, as well as a component of entertainment.
Truly spoke out their names. So that's the way. We don't copy paste. We're unique. We don't do the teams of the IPLs of the sorts. We are OPL.
Good teamwork, excellent presentation by each one of you, and each one of you is a winner.
Cheers to all the teams. The tremendous amount of work that they've put in. We get crazy doing one scientific presentation, but they've put in everything, entertainment, music, everything that you could think of. So congratulations to all the teams. Thank you.
That's what speaks about women. They multitask on the slides as well. Wow. I think can we have a picture of the umpire? Yes. Where's Joel? Come. Photograph. Yeah, yeah. Quickly announce the result, and I would say 3 cheers to PL Boss till we see again. So maybe we'll post the result on the AIOS platform, maybe in another some 15-20 minutes. Calculation.